Thank you, Dr. Mohammed Saeed, for the nice presentation. Thank you, Dr. Amirvet, for inviting me for this meeting. My talk is about comparing PFA to RF and cryoablation regarding clinical outcomes and safety. We all know that atrial fibrillation is the most common arrhythmia encountered in clinical practice, and the prevalence of atrial fibrillation has increased significantly in the past 50 years. And it's said to be the disease of aging. The main problem of atrial fibrillation is the increased risk of morbidity and mortality due to thromboembolic risk and increased the risk of heart failure. Therefore, it requires timely intervention and treatment. Over catheter ablation of atrial fibrillation has evolved to be a highly effective treatment strategy for rhythm control, and pulmonary vein isolation remains the cornerstone or gold standard for AFib ablation in paroxysmal and persistent atrial fibrillation. Based on the current evidence available, the most recent European guidelines has recommended catheter ablation of atrial fibrillation catheter ablation of atrial fibrillation as a class 1 indication for drug-resistant paroxysmal and persistent atrial fibrillation, and recommended it as a first-line therapy for patients with paroxysmal atrial fibrillation. For years or for decades, catheter ablation of atrial fibrillation has been exclusively performed by thermal energy, either radiofrequency ablation, which creates lesion by heating up the tissues, cryo balloon, which creates lesion by freezing up the tissues. But most recently, in the most recent years, there was another form of energy, which is believed to be non-thermal energy, or it claimed to be non-thermal energy, known as pulse field ablation, or PFA, that creates lesion by a process known as electroporation. And I will talk about it in details later on in the talk. And it's believed to be cardioselective, so there is no risk of collateral damage, in contrast to thermal energy that is not cardioselective. It doesn't discriminate between tissues, so there is a risk of collateral damage when used in thermal energy, but it's proved to be very low risk. Early on, during AFib ablation, RF energy was the first used modality or energy used during AFib ablation, and it's a point-by-point modality. For creation or achieving pulmonary vein isolation and creating any other lesions in the left atrium and the right atrium. And over the years, there was technical advances in this modality, including the introduction of contact force, high power short duration, lesion indices, and very high power short duration, and all of these aimed at increasing the long-term success rates, with 1 year success rate or arrhythmia-free survival of reaching up to 80% in paroxysmal atrial fibrillation, and also increasing the durability of the lesions, reaching up to 80% in some studies, also decreasing the procedural time. The pros of this modality is the versatility. You can do pulmonary vein isolation and any other lesions using this modality. Also, it's the preferred modality for redo cases. The pros also is the less radiation exposure, but the cons is the risk of collateral damage, because it's a thermal energy and a longer procedural time compared to other modalities. A few years later, there was the introduction of cryo balloon for AFib ablation. That was a breakthrough. It's a single shot technology using balloon catheters with injectors with nitric oxide that's injected inside the balloon to freeze up the tissues and causing tissue damage by freezing up the tissues, and then achieving pulmonary vein isolation at the end of the procedure. The pros of this modality is the shorter procedure time compared to RF ablation, the uniform lesions or consistency of lesion, because you create your lesion simultaneously by the balloon, and more tissue stability, because once you freeze up the tissues, the balloon sticks to the tissue, gaining more stability. The cons is non-versatility. It's only confined to pulmonary vein isolation. You cannot do any other lesions with it, hypothetically, and also it's not the modality it's not the modality of choice for redo cases. Also, there's a longer fluoroscopy time compared to RF energy, increasing the radiation exposure, and also the risk of collateral damage because it's the thermal energy. And several studies have compared cryo a balloon to radiofrequency ablation as regards safety and efficacy. And this is one of the studies that compared both modalities, which was published back in 2019, and showed non-inferiority of cryoballoon as regards efficacy, efficacy compared to RF ablation. Also, as regards safety, both modalities were comparable. It was non-inferior to RF energy as regards safety, but there was recorded a trend towards a higher risk of phrenic nerve injury with cryoballoon that was not reported with RF ablation. And also, there was significantly longer procedural time with RF ablation, but significantly shorter fluoroscopy time with RF. Now we come to the new kid on the block, or the new modality or energy, is pulse field ablation. In this modality of energy, the lesion's formation is formed by applying rapidly alternating high electrical fields to cardiac tissue, creating nanopores in the cell membrane of the cardiac cells, subsequently leading to cell death or apoptosis, a process known as electroporation. This is a non-thermal energy, highly cardioselective with a larger safety profile. The ablation voltage used is around 1.8 to 2 kilovolts in some systems and 1.5 to 3 kilovolts in other systems. This is a very low voltage or low threshold to create tissue damage. And the number of applications differ depending on the system used. As we can see here, once you apply your PFA, you lose your pulmonary vein potentials and you establish your pulmonary vein isolation in few seconds using the different system. This is the FARAPulse system, and this is the pulse select system, and you gain 100% isolation of the pulmonary veins, acute success rate, and good durability of lesions. Currently, there are a lot of systems, PFA systems, that are under development or under investigations, but the ones that are out on the market or almost out on the market are the FARAPulse system, the Pulse Select system by Medtronic, the VarioPulse by Biosense Webster, and the Volt, and all of these are single shot PFA systems. And as far as the point-by-point systems, there are several are under development, but the one that is about to go into the market is the Affera catheter, and this is a dual energy catheter, holds PFA together with RF. As far as efficacy of pulse field ablation, we know that the first system that was out on the market is the FARAPulse, and the FARAPulse was under extensive investigation as far as efficacy and safety. And one of these studies is the Manifest PF registry that included a large number of patients. It was a multi-center retrospective registry, included around 1,500 patients undergoing pulmonary vein isolation using FARAPulse, and it shows 1 year survival rate or success rate of 81% for paroxysmal atrial fibrillation and 71% for persistent atrial fibrillation. And the second system out in the market was with the Pulse Select by Medtronic, and it was studied in this study that included 300 patients undergoing pulmonary vein isolation, and it showed almost the similar results, success rate of 1 year success rate of 70 to 80% in paroxysmal atrial fibrillation and 60 to 80% in persistent atrial fibrillation. And the safety profile of these systems reported in these trials was quite favorable. The major complication rates reported was around 1% or less than 1% in both studies. But the largest to date safety trial that evaluated pulse field ablation system was the Manifest 17 case study that included more than 17,000 patients. 17,000 patients in 100 centers over a year, 1.5 years, examining the safety of FARAPulse system, and it included 60% patients with paroxysmal atrial fibrillation, 35% with persistent atrial fibrillation, and the reported major complications with only 1%, and the minor complications with around 3%. The most common complication was the minor vascular complication. The second in line that comes is the pericardial tamponade. It was about 0.3% or almost 0.4%. The energy-related complications that were unique and we've never heard about before with other thermal energies was the coronary spasm, reported only in 25 patients, and is caused by I will need only 3 or 4 minutes. It's a proximity spasm due to off-label lesions, CTI lesions, and mitral isthmus lesion. Also, there was the hemolysis-related acute renal failure, only reported in 5 patients, and all of them were persistent atrial fibrillation with extensive lesions and large number of lesions. The mean number was 143 lesions. This is quite a lot. And stroke was reported in 22 patients due to catheter exchange, because this system has a huge or a large delivery system with an inner diameter of 13 French and an outer diameter of 16 French. But what is remarkable is there was no reported cases of atrioesophageal fistula and pulmonary vein stenosis, but there was few cases of phrenic nerve paresis. When we compare pulse-filled ablation to cryoballoon and radiofrequency ablation, there was this study that was published last year in Europace that that compared the 3 modalities, and the results of this study showed that the PFA had significantly lower procedural time compared to the other modalities, but fluoroscopy time was significantly lower with RF. As far as major complications, there was no significant difference between the 3 modalities. And it's very important to see that atrioesophageal fistula, pulmonary vein stenosis, and coronary spasm was not reported in either one of the modalities. But as far as the minor complications, they were significantly lower among PFA patients. Also, PFA patient had the least amount or the significantly least number of pulmonary vein reconnections in redo cases. About efficacy, there was no significant difference between the 3 modalities as far as 1-year survival, arrhythmia-free survival rate. They were 3 of them were 3 comparable, but there was a trend towards a lower incidence of AF recurrence with PFA. When it comes to persistent atrial fibrillation, this study that was published last year in Heart Rhythm compared the 3 modalities, and 80% of PF patients were done under 3D mapping system, and we can see here a significant increase in the procedural time when we use 3D mapping with PFA, but still is significantly lower or shorter than RF ablation. As far as the pre-procedure complications, there was no difference between the 3 modalities, but there was significant increase in reported cases of phrenic nerve injury with cryoballoon. As far as the 1-year arrhythmia survival rate, PFA did better, significantly better than RF, but it was comparable to cryoballoon, and the addition of posterior wall isolation didn't interfere or didn't change the success rate. As far as our Egyptian experience, we are proud to say that currently we have PFA systems here in Egypt in 3 centers, starting from the year 2005, and the 3 centers started to do cases of PFA using FARAPulse, which is a single-shot PFA system, and we are looking forward to having it in other centers by the end of the year. And this is one of our patients that we did in our center under the supervision of Professor Mervat Abou Maati. This is a patient who is 50 years old, had recurrent paroxysmal atrial fibrillation refractory to antiarrhythmic drugs, and we did a CT pulmonary vein angiography before going into the cath lab to delineate the anatomy of the pulmonary veins, showed 4 separate pulmonary vein potentials. And here we see that we did the procedure under fluoroscopy guidance, and we did that single transeptal puncture under fluoro and TE guidance, since we can appreciate the pentaspline catheter over the wire into the left atrium. Here we can see the catheter in different shapes and in different pulmonary veins. And here in the basket, basket shape and the flower shape, and here we apply the PFA. We can appreciate complete disappearance of pulmonary vein potentials after application of the PFA, and the patient is doing well, and we did it in very short time. So in conclusion, the AFib ablation using thermal energy, although largely safe and effective in hand of expert operators, it carries the risk of severe complications like pulmonary vein stenosis, phrenic nerve injury, or atrioesophageal fistula. And common to all thermal energy, we all know that it has the propensity to ablate all tissues indiscriminately. In contrast to PFA, that is a non-thermal ablative modality with cardioselectivity, so it has a higher safety profile. Many studies have shown that PFA rapidly and efficiently isolates pulmonary veins with a degree of tissue selectivity and safety profile. But still, PFA has challenges. First, the lack of standardization of protocols for PFA, including energy delivery parameters, that makes it difficult to compare results across studies. Furthermore, PFA has known to lead to complications. It's not, completely safe after all. It can cause coronary artery spasm, hemolysis-related acute renal failure. It can cause phrenic nerve stunning that is transient. Actually, it recovers completely. So further research is necessary to develop methods to prevent such complications effectively. And lastly, pulse field ablation is a novel procedure that is very expensive, and certain financial factors can limit its widespread use and its accessibility to all patients. Thank you.
Rania, allow me to ask you a little bit of a long question.
Yeah.
So I'll ask the questions and tell you why I'm asking it.
Okay.
Do you think the advantages of the PFAs come from the source of energy or from the design of the catheter? Because, well, I mean, like in cryoablation, I think we are technologically stuck here because it's a gas, it has to go to a contained cylinder. But when we come to the RF, for example, when the FR is bringing their catheter, I think next year in the market, with the unipolar RF, and at the same time, the PFA, you can use the same catheter for both. From my discussion with them, the unipolar RF with the new distancing in electrode, they solved a lot of the problem of the end mark before, which caused a lot of strokes. So, and I think they go for that during the end marks. There have been no atrioesophageal fistula or perforation, but just this stroke. So when you would get the affair in market, and for example, if you have it in your center, we'll use it as single shot RF or single shot PFA. Is it the source of energy or the design of the catheter?
The Affera is not a single shot. It's not marketed as a single shot. It's a larger footprint point by point ablation catheter, and I think people are enthusiastic. I'll tell you what, I can use it for AFib, but I think the main use or the advantage of this affair is going to be with the VT cases. But if I'm going to use it in the left atrium, so I'll do my lesions, especially if it's with posterior wall lesions, it's going to be using PFA. Anteriorly, I can resort to RF. So I can do the anterior lesions, especially the ridge lesions with the RF, and the posterior antral lesions, and if I'm going to do a posterior wall lesion, it's going to be purely with PFA for the risk of collateral damage.
What about this basket catheter? I don't know the name of Medtronic. I mean, that will come as unipolar RF, a single shot, because it will be, I think, 16 electrodes, I think, of RF and
the PFA is RF and the PFA.
PFA, yeah, but it will be like the basket, and they will use it as I mean, I don't think that I said the name right, but they will have a single shot catheter.
Yes, okay.
RF and PFA. So is it the source Medtronic? So I think they will commercialize as it looks like the basket as single shot RF also, as unipolar RF, like the end mark, but with different distancing, so to solve the problem of the.
Well, based on the data available, I will use it for as PFA because of two things: the safety profile of this energy over the RF. Secondly, because the initial study says that durability of pulmonary vein lesions are better with PFA compared to RF.
But this is as one point, huh? I mean, like, this was not single shot. So you believe that the PFA would be the source of energy, which has the advantage over the design of the catheter?
Yeah. Yes.
Thank you very much, Dr. Rania. Thank you for all speakers and my chair coaching this session. Thank you, African Egyptian Heart Association, for inviting the African Heart Rhythm Association to be in this co-joint session and giving us the chance to present our latest development in the arrhythmia technology. Thank you very much.